Greetings, my name is Carmen Robbins, and this PowerPoint will serve as a visual representation of my paper titled Austerity and Disparity in Underserved America. On today's agenda, we're going to talk about health disparities, vulnerable populations, rural Appalachia, and initiatives and solutions to health disparities. So, what is a health disparity? It's a specific kind of health difference between more or less privileged groups. And why is this important? The United States is transitioning from reactionary to preventative through evidence-based guidelines in terms of primary, secondary, and tertiary prevention of disease. When one group that is already predisposed to poor health due to low income and the lifestyle which low income is associated, they often do not have access to routine screenings as recommended, such as routine colorectal exams, mammography, dental, and vision. Vulnerable populations are best defined as populations having a predisposing characteristic or characteristic that creates a disparity in the way they are treated, their access to care, and the availability of resources at their disposal. Some of these defining characteristics include social structure, demographics, and health beliefs. Socioeconomic status is a powerful predictor of a person's health. In particular, vulnerable populations are those with predisposing social structure characteristics, including ethnicity, education, occupation, family size, religion, and country of origin. Disparities of social structure are what we often associate with vulnerable populations, as these characteristics are often most visible and tangible. Race and ethnicity are important influencers of health. The United States currently identifies 5 different racial groups: African American, American Indian, Asian, Hawaiian, and white. Additionally, the U.S. identifies 2 ethnic groups: Hispanic and non-Hispanic. A person's race and ethnicity can be a powerful predictor of their health. Genetic predisposition to certain conditions such as hypertension and cancer can often be compounded by a group's perceptions of health as well as socioeconomic status. For instance, African Americans experience the highest level of all mortality of any racial group. Additionally, some racial and ethnic minorities tend to, as a group, be less trusting of a healthcare system. The roots of mistrust have, in some cases, precipitated past treatment of a large number of a specific group, such as the highly unethical Tuskegee syphilis experiments. So I wanted to show you guys this chart which shows numbers, comparison of whites, blacks, Hispanic, Asians, and Indians, and it just proves that African Americans have the highest rates in all of these categories, such as infant mortality, cancer, lung cancer, stroke, homicides, HIV. So Western medicine has historically been slow to incorporate diverse views regarding life, health, and death into practice. Cultural perspectives on diet, administration of medications, modesty, gender preference of healthcare providers, the presence or absence of family members, and other diverse cultural mores all have the potential to improve or impair healthcare delivery. The impairment of healthcare delivery, of course, contributes to disparity. So in general, a person reliant on others, such as the very young or very old, as well as persons at increased risk for abuse, such as women during pregnancy, and the chronically disabled are often those with the greatest and most unmet needs. Additionally, those with behavioral or mental health problems often find that they have little or no health care coverage or access to care during their times of need. For instance, those experiencing an acute mental health emergency, such as severe situational depression or suicide, often incur huge personal expenditures for counseling and medical treatment, or they go untreated. Those with chronic mental health conditions who are underserved are at increased risk for medical comorbidities and even homelessness. The social domains of the medical underserved include the homeless, immigrants, the incarcerated, and especially the impoverished urban and rural populations. So, according to the documentary The Invisible Patients, there are approximately 5 million homebound or home-limited adults in the United States. The following excerpt is from a documentary called The Invisible Patients. Jessica McLeod is a nurse practitioner who goes to these rural areas, and she explains the importance of access to care in critically underserved areas.
If I wasn't doing it, I would bet the ER in a
So now she discusses a possible
more caregivers, more aides, just more people need to help these families.
So in rural areas, compared to urban areas, they have unique challenges associated with the lack of convenience and decentralized lifestyle. They have more poverty, more suicides, lower education levels, more hazardous occupations. I wanted to show you, these numbers are from 2014, so the Affordable Care Act has probably changed this a little bit, but there's definitely more uninsured people in rural areas. So who is helping? RAM is a nonprofit mobile medical service founded by Stan Brock in 1985. While living in South America, Stan suffered an injury in a remote area that was a 26-day journey away from medical care. This inspired him to help people in remote areas receive basic level of care. RAM is staffed by volunteers and offers services such as medical, dental, and vision screening. People travel great distances to wait in line for days for this care and even sleep in their cars. It's not uncommon to see children walking great distances to these events barefoot. So one solution to healthcare disparities on the state level is to offset critical provider shortages to expand the scope of practice for advanced practice providers. In many underserved areas, advanced practice providers are not legally allowed to practice independently. This map currently represents which states practice full practice authority and which require varying degrees of collaborative practice with the physician. Although rural Appalachian falls in a highly restrictive area, requiring collaborative with physicians who are already in short supply. So here are some federal programs that benefit underserved areas. I wanted to talk about the Conrad State 30 program, which allows states to bring a predetermined number of foreign physicians in exchange for their service in a shortage area. Another example is a federally qualified health center program, which is a critical part of the health safety net. They are supposed to provide assistance to rural and urban underserved areas. However, between 2007 and 2014, 80% of them were opened in urban areas. While they were intended to benefit both areas, a disproportionate amount of funds ultimately went to urban areas. So in conclusion, certain health disparities are predictors of a person's health status. Identifying underserved populations is a good first step. However, changes are needed at the provider level to help in health disparities. So thank you for listening, and let me know if you have any questions. Thank you.